All right, guys, so today's lecture is going to focus on colon cancer screening. Now, colon cancer screening is, kind of a touchy subject. A lot of patients are reluctant to actually get colon cancer screening because they only feel like we have one option available, the colonoscopy. Now, I'll be the first to tell you, colonoscopy is probably the best test to screen for colon cancer, but there are other options. In fact, the USPSTF recently announced in this month, June 2016, they announced 4 additional options for colon cancer screening. So as of right now, we have 7 different options, that we can offer our patients. Now, still, by far, in my opinion, the colonoscopy is going to be the best screening tool that we have available, but it's up to you to educate your patients. It's up to you to inform them, because ultimately this is, kind of one of those shared decision models. Now, the USPSTF is really advocating any screening. They don't really care what you offer your patients, so long as you offer an option that they were willing to do. Because as of right now, there's only about 60% of those that require colon cancer screening are actually being screened. So they have the USPSTF has this lofty goal to actually get 80% of patients. So those that are supposed to be screened, we have a goal of 80% to screen by 2018. So what are the options, right? Well, colon cancer screening really starts at age 50 and we go to 75 years of age, so long as we have a 10-year life expectancy. We had 3 original options, which you're aware of. We have the colonoscopy, sigmoidoscopy, and we have fecal occult testing, which is guaiac stool testing for occult blood. Now, colonoscopy, right? It's got the best sensitivity, it's got the best specificity, but the problem is it's invasive. The problem is the fear. A lot of patients are scared of what might happen when we do colonoscopy because all they're aware of, especially if it's the first time, is what they've heard, what their friends have told them about it, right? There's bowel prep involved. There may or may not be anesthesia. So, these are things that are very scary to a patient. But colonoscopy has the best sensitivity and the best specificity. Sigmoidoscopy and colonoscopy we do once every 10 years, which is great. Sigmoidoscopy we do once every 5 years. The problem is that we can only identify lesions or possible colon cancer that's in the distal bowel. 60 centimeters lesions in the distal bowel, right? So anything above or anything proximal to that, we're going to miss. Then we have stool occult testing for blood. This is done every single year, and the problem with this is that it's not very specific to clinically relevant disease, meaning it's only testing for blood, but it doesn't tell us where the blood is coming from. Hemorrhoids, for example, are a very common problem. Hemorrhoids can cause bleeding. This will test positive on stool occult testing, and guess what? If the stool is positive for heme, for blood, then we have to do a colonoscopy anyway. Now, it's not that we do colonoscopy every 10 years, sigmoid every 5, and stool testing every year. It's we have the option. Those are 3 different options. We can do either this, either that, or either the other. It's not all 3, right? So the easiest thing is really stool testing every single year, but it's by far the worst test. The best test is colonoscopy every 10 years, but it's the most invasive test. Now, like we said, screening starts at age 50, ends at 75, so long as we have a 10-year expectancy. The one caveat or the one exception here is if we have Lynch syndrome, which we would then start screening at 25, but more importantly, family history. So if we have one first-degree relative who was diagnosed with colon cancer before age 60, then we're going to start screening at age 40 or 10 years before they were diagnosed. So if your first-degree relative was diagnosed at age 49, for example, then we're going to start screening at age 39. So it's either 40 or 10 years before they were diagnosed, whichever comes first. Or if we have 2 first-degree relatives diagnosed at any age. So if we have 2 first-degree relatives both diagnosed at age 70, we're going to start colon cancer screening at age 40, right? 40 or 10 years before they were originally diagnosed, whichever comes first. And we do screening every 5 years. Like we said, Lynch syndrome, we're going to start screening at age 25. All right, now, what are the new tests that are available? Well, like I said, the USPSTF has announced 4 new options, right? So we have fecal immunochemistry testing, and this is also stool-based. This is long for FIT, so we call it FIT, right? So FIT is done every single year. This is stool testing. This is supposed to be more sensitive than the original stool testing, but it's more expensive, right? So it's probably not going to be covered, and it's going to be more money. So that's one option. Second option is sigmoidoscopy plus FIT. Third option is going to be with CT colonography. Now, CT colonography, think about this. We're using a CT scan, a CAT scan. We're giving radiation to screen for cancer, but yet when we give radiation, we increase the risk of cancer. So that's the downfall with CT colonography. And finally, we have stool DNA testing. Now, stool DNA testing is supposed to be more sensitive than FIT, but it's less specific. Again, this is going to be stool, right? So we have 3 stool options. We have CT colonography, and then we can do FIT plus sigmoid. Because these are semi-new, it's not clear as to how frequently these should be done, but it seems like most people who are doing stool testing are doing this every single year. They all have pros, they all have cons. The USPSTF does not care which screening method you have the patient do, so long as they choose one and they are screened for colon cancer, because all of these methods, all of these options are going to reduce mortality in the patient. Ultimately, that's our goal. Reduce mortality, reduce morbidity, reduce disease burden. This is a preventable cancer if we diagnose and we screen when we're supposed to be screening. Remember, colonoscopy is the most sensitive and the most specific, but it's the most invasive. Stool testing is the easiest, but it's the least specific. And if it's positive, we still have to go to colonoscopy. At the end of the day, it doesn't matter so long as your patient is informed and they choose a screening method. Remember, we start everybody at age 50 unless we have a family history. If we have a family history, we start at 40 or 10 years before the first degree relative was diagnosed. This was colon cancer screening. If there are any questions whatsoever, send an email to elite@physicianassistantboards.com. More than happy to answer any questions, and I'll see you on the next lecture. Take care.